I want to welcome everybody. It's probably been a long day for you. It was a long day for me in practice. I was in with patients up till about 30 minutes ago, and today was one of those days you don't like. I prepped 4 crowns on 4 different patients. All of them were lower second molars. 2 of them had wisdom teeth right behind them. So it was a day. Also cemented a bunch of crowns, and we're talking about some cements tonight, so that's apropos. And I just want to give a shout out to Catapult for asking me to be here with you, and to Doxa Dental for sponsoring tonight's program. With that said, I want you to know that the Catapult organization and myself work with a lot of industry companies, leading companies in industry. And these are the companies we work with, many of dentistry's companies. And tonight, Doxa Dental has asked me to present on their behalf. Now, with that said, you need to know that I'm not a hired thug of Doxa Dental. I use their products on a daily basis in practice. I'll show you that, and have for many years since their inception in the mid 2000s. So with that said, we'll go ahead and get started. Now, before we get into the bulk of the program, I want to give you my email address. Take a screenshot, whatever you need to for this. And if at the end I don't get to your questions, I'll be happy to answer them via email. So feel free to email me at mgeisbergerdds@gmail.com. I'm also Marin Dentist on Instagram and Mark Geisberger DDS on Facebook. And with that said, I'll give you a brief introduction myself. I am an educator. I've been an educator for 30 years. I taught at University of Pacific in San Francisco, graduating in 1991. Became a full professor and chair of the Department of Restorative Dentistry for 15 years. After teaching full-time, and during teaching full-time, I also maintained a private practice with my father and my brother in Marin County, California. I've just celebrated 30 years in clinical practice and loving every minute of it. In addition to that, I do a lot of product evaluation with companies, helping them bring new technologies and deliveries to market. And as I mentioned, I'm a speaker with Catapult Education out of Chicago, Illinois, founded by Lou Graham. My family and hobbies, I have a wife and 3 kids. I do car restoration, woodworking, organic gardening, and painting. So that's how I spend my free time. Well, I want to start with some opening thoughts. And we're going to talk a bit about, for me, a very critical part of the oral environment, and that is oral pH, and how devastating pH can be if it's not controlled. So I want to give a shout out to some product lines that I think are really, in the United States, underutilized. The first is glass ionomers, and glass ionomers are really silicate glass powders combined with polyacrylic acid. And we know that glass ionomers are able to release calcium, and they can release small amounts of calcium, but more importantly, they really release what we call fluoride. And fluoride is hugely important in an active caries patient. But with that said, glass ionomers in an acidic environment will wash out, and they're not stable in an acidic environment. Now, resin-modified glass ionomers do also release fluoride. They're a combination of organic resins, basically composites, added to glass ionomers. Now, the problem here is that limits the release of the fluoride. Both of these have an incredibly low pH. And when they're in an acidic environment, they tend to wash out. Now, bioceramic glasses or cements are comprised of really calcium aluminate and components of glass ionomer. Now, what the calcium aluminate does is provide large amounts of calcium to the restorative material, which raises the pH dramatically and makes it highly resistant to acid degradation. In addition to that, it makes the environment in which it sits far less favorable to bacterial infiltration. So for me, they represent a class of materials that do have some distinct advantages over glass ionomers. Now, with that said, I use glass ionomers routinely. And there are certain situations where I simply have to use a glass ionomer and love to use a glass ionomer. That's where I can't control moisture and I'm in a high caries risk patient or a geriatric patient, and I'll use it as my patch and pray material quite frequently. Now, I want to show you this patient, and I'm going to ask you how old they are. Well, when you look at the teeth, most of you, when I give you these options, would probably say they're somewhere between the age of 40 and maybe over 65. You'd pick 3, 4, or 5. But in fact, this patient is 32. And they've been devastated by acids. Now, these acids for this patient happen to be driven by habits. And their habit was the ingestion of lots of acidic containing liquids and food sources. All right, so take a look at these drinks and tell me which one is the most erosive. Well, a lot of you probably guessed Coca-Cola, but we've all heard how erosive that is. But actually, of the 5 here, it's the least erosive. The other 4 are actually the most erosive, and that has to do with what acids are present in them. Powerade, Mountain Dew, Gatorade, and Red Bull all contain citric acid, and citric acid is highly devastating to restorative products, particularly glass ionomers and composite resins. When your patients do this habit of drinking these over long periods of time, they really have a detrimental effect on those products. Now, when we look at the bioceramic glasses, those materials are far less resistant to acid degradation because of their high pH tendency. The most devastating here is actually Mountain Dew. Now, when we studied these 4 drinks, and I published this some years ago in the Journal of the California Dental Association, we looked at the recovery time, meaning if I take a sip of, say, Powerade or Gatorade, how long does my mouth take to return to normal? How long am I bathing my restorations and my teeth in acids? And the answer is it's quite staggering. When you look at Red Bull, Gatorade, and Powerade, they take between 18 minutes and 22 minutes to recover, meaning with one simple swig, you create a hostile oral environment for your restorations that are prone to acid breakdown, composites and glass ionomers. Now, if you're using a glass ionomer or composite cement, imagine that getting under a crown margin and beginning to degrade that area. Couple that with high sugar concentration, and you get marginal breakdown, recurrent caries. So tonight we're going to talk about a couple of products that really can help you in this environment where you see a lot of acids present. Oddly enough, Coca-Cola, being phosphoric acid based, really recovers quite quickly. So it does not actually devastate the oral cavity nearly as significantly. Now, here's some pHs of other drinks and the acids they contain. But let's face it, most of these drinks are acidic except for really green tea, which is the one of the rare few basic drinks. Even your Starbucks coffee in the morning is somewhere between 4.3 and 4.6, depending on how dark the coffee is and whether you might buffer it with some calcium. Now, when you get to liquors, they're the worst, and in fact, the worst drinks and the most modern drinks, those White Claws and Trulias, those are devastating. Why? Because they contain, again, citric acid and a very low pH. Couple that with high sugar concentration, and you're in a lot of trouble as far as creating an environment that's perfect for breakdown and caries. So with that said, I want to talk a little bit about resin-free cements and where they may fit into this area. Now, these came out in the mid-2000s, and I was immediately drawn to this product for a number of reasons. One, it told a great story of dealing with acids, and I speak on acids all the time, and this was something that fit really well into my practice. So let's talk a little bit about bioceramic luting cements. Now, first of all, these are comprised of calcium aluminate in conjunction with a glass ionomer component. The calcium aluminate provides that pH balancing and provides calcium in large amounts, far greater than you'd ever see in any restorative material, to the margin of the restoration and to tooth structure. These react with water, first dissolving and then recrystallizing as a nanocrystalline hydrates, basically apatite. And what that does is, believe it or not, this helps to reseal margins. Now, with that said, these materials create a bond through surface energy and mechanical interlocking at a nano level. And they really react with not only the two structure, the cement and the restoration together, really leading to superior sealing through this mineralization and apatite development process. So this is one of the few cements you'll ever see that can demonstrate very clearly the growth of apatite and sealing of a margin over time. And that to me is fascinating. Now, I've been using this cement continuously since around 2012. That's 10 years. The other thing that I find quite interesting with this cement is its pH. Its final pH after about a day of setting is about 8.5. Now, what that means is that constant 8.5 pH wards off acids and creates an environment that is counterproductive to bacterial growth. So when you have an 8.5 pH, bacteria that like to swim in acids don't do well. So this is also anti-cariogenic. And the material responds very well to tissues. Now, with that calcium aluminate glass ionomer Ceramir product, it is different than these other cement types on the market. RMGIs and their group, as well as GI cements, adhesive cements, and self-adhesive cements are different than Ceramir. And Ceramir is really that one cement in this calcium aluminate group of cements. Interesting, Jeffrey showed in his 2015 study that during and after setting, the cement released calcium ions that then created this alkaline environment, which then was optimal for hydroxyapatite formation. And at baseline, you saw that marginal gap that may be 2, 3, 10, 20 microns. And after 48 days, that margin was essentially sealed and highly resistant to acid degradation. Now, that's not necessarily true with a glass ionomer cement or even a resin-modified glass ionomer cement. That can, in an acidic environment, begin to wash out. So this is one of the key principles when we're talking about these calcium-based cements. And when you see these compared to the study, comparing it to, say, a self-adhesive resin cement or a resin-modified glass ionomer or a true glass ionomer, there was really no difference in those three types compared to the baseline that showed that growth of apatite at the margin. And that's this reaction with water that works beautifully. Now, the calcium also helps to neutralize the pH of the cement, which is incredible. And when I first was introduced to this product, what I learned was that the patient would have very little post-operative sensitivity. And I was puzzled by that. And really it got down to the fact that this is one of the only cements that is not acidic. Now, when you take an acid and you place that on two-structure, exposed dentin, that acid enters the dentinal tubule and can, in fact, induce a pulpitis. So when you put on a cement on a patient without anesthesia that's acidic base, they're going to feel it. They're going to like, whoa, and that feeling will dissipate over time, but it may set up an inflammatory process. Now, the interesting thing I've noted in practice, I did this on the 50 first patients I used Ceramir cement on. I said, here's the deal. We're going to do this without anesthesia. No anesthesia. Because the cement reacts with water, I don't need a totally dry tooth. I need a moist tooth, blotted dry with cotton. So I'm not going to put an air in your tooth. We're going to just clean it off with cotton. We're going to place the crown, and you're going to tell me on a scale of 1 to 10, being 1, I felt no pain, 10, I felt excruciating pain, what's the number? And I asked each and every one of these patients, and what they told me each and every time is, it's a 1. Well, my 50th patient out of the ones I treated, I finally did it on a truly dental phobic. The type of patient you look at and they're like, ow, you're hurting me. And you say, I haven't done anything. And they're like, it still hurts. So I asked this patient here, you got to trust me. I'm going to cement this crown without anesthesia using this technique. And you're going to tell me on a scale 1 to 10 if it hurts. So I do the whole procedure and I'm watching her eyes and she's not moving. And I said, okay, scale 1 to 10, did that hurt? And she goes, well, I'd like to give it a 1, but I have to say it's a 2 because I thought it was going to hurt. I'm like, okay, then it's a 1. So there you go. Very little inflammatory process. Now, easy cleanup. This just peels off. No pre-treatment required. It sets in a moist environment, which is beautiful. You just put a cotton roll and walk away. No post-operative sensitivity. In fact, patients come back a week later, whatever, recall, hey, how's that new crown? Oh, great. It's been fine since the day you cemented it. And that's what's fascinating. So many other cements will induce that pulpitis and they'll suffer for a period of time. That alkaline pH then helps ward off caries and prevent bacterial infiltration and grows that appetite. And like a GI, this does release fluoride. There's no shrinkage. In fact, there's growth at the margin. And it's hugely stable over time, creating that high retention. So for me, it's really an ideal cement. Now, I want to show you the first clinical case we did at the university with the cement. And this was actually a full mouth reconstruction. And I'd read up on cement I was using in practice. I brought it to dental school and I was working with a student on a full mouth reconstruction and said, hey, listen, your patient's bulimic. Now, we think she's in remission, but if she isn't, she's going to flood all of our crowns with acid constantly. And we need a cement that's going to, number one, help neutralize those acids around our margins and really ward off the effects of those acids, number two. So we kind of built this case around that in mind. Now, she had been a bulimic for 15 years. She literally destroyed her teeth, worn them down through bulimia. And you can see the destruction where she'd lost more than half her tooth structure. When you look at the occlusals, you can see how devastated the lingual was and how devastated the occlusal of the lower posterior were. And she really needed a full mouth reconstruction. Now, we toyed with a lot of different plans. And the reality was we came up with reconstructing her at a new vertical dimension. So we, working with a third-year dental student, had him do some simulations and functional try-ins with his wax-ups. We finally got to the point where we had some shapes in place, and he was able to prep 28 units on this patient and restore her using, at the time, this is going back now over 10 years, we used lava crowns, which were a layered zirconia crown. And zirconia is a perfect product to cement with ceramere. So we did that. We used a splint. This is after we had prepped the posterior teeth. That's a splint at her new video just to guide the student through this process. We got the posterior units fabricated and cemented with the ceramere. We then turned to the anterior teeth, prepped the anterior teeth, took our impressions, and then used the ceramere cement to cement these. Now, you can use this in 2 varieties. At the school, we used the quick cap. Because we had triturators everywhere, we'd activate, triturate for 10 seconds, express the cement, seat the crown, let it gel for 2 to 3 minutes, and clean off the excess. If you don't have a triturator anymore, you can get the ceramere quick mix that allows you to hand mix the cement by applying drops of the liquid and a scoop of powder. So these were all cemented using the ceramere cement. And this patient was tracked. And the interesting thing on these badly damaged teeth where she had eroded near to the pulp, she had no post-operative sensitivity and not a single tooth required a root canal following any of the treatment. And that can't be said in many cases. She went from there to there, a beautiful result, great restorations, and they're all still intact to this day. So real fun application of the cements. There's lots of literature showing that when you restore vertical dimension, you make the patient look anywhere from between 5 and 20 years younger. And I think we accomplished that. She went from there to there, there to there, there to there. And the tissue response around ceramere cement is impeccable. Well, taking this a step further, I want to mention this bioceramic implant cement from ceramere. And this is really a twin brother of the ceramere cement that we use in conventional dentistry, really designed around implants. This works extremely well in implants. And one of the issues we have with implant cements are, one, if excess is left behind, many cements aren't radiopaque enough to be detected. The second issue we have is the peri-implantitis or perimucositis that can be triggered by the presence of cement on an implant. Now, the cement works in the same way as you saw with the Ceramir. It reacts with the water, first decrystallizing and then recrystallizing into a nanohydrate, that apatite crystal, and it creates the same bond through that surface energy. It's shown to have great remineralization in the case of a crown, a marginal sealing effect, because we're not remineralizing implants, and it's hugely tissue friendly. So you don't see that reaction around the tissue you do if some excess cement is left. Now, when it was studied in a viability test against cell viability against, say, a resin RMGI and a ZOE, it had a great viability score, well over 100. And that's excellent when you look at biocompatibility. That's a great measure of biocompatibility. The thing I like about this is it's very easy to clean off from your implants. Now, I want to give you a few little tips on implants when you need to cement them. My recommendation with implants is always that when you can, you don't cement implants, you screw them in. But sometimes the angle at which we place an implant doesn't allow us to screw retain the crown. So we're forced to use cement, and that's fine. But if you're going to use cement, you want one that's biocompatible like this, one that is easily identified in a radiograph like this, and a cement that is easy to clean off and not going to be so sticky on the ceramics and the titanium that you can't clean it up. And really, the Ceramir cement for implants works extremely well with this application. Now, if you do happen to leave some interproximally, you want to be able to see it in a radiograph. If it's a resin cement and you've got this cement down to the crown margin, it is going to be very difficult to remove. But with Ceramir, when you take your post-op x-ray, and I suggest you do that with all cement retained crowns, you do see that cement. The cleanup is simple. You take another film and you'll see that the cement is gone immediately. So it really allows itself to that easy cleanup and use of floss, gets it out of there, and very radiopaque. Now, this is a clinical case we did on a very challenging situation where we had initially a flipper in place, and the patient was tired of that, but we wanted to develop the implant site for the proper contours, and began plumping out the papilla and starting to shape those, and was using a flipper to kind of go over this, but it didn't look all that good. So we came up with a unique idea of making a little composite bridge. This is solely made out of composite that was quite thin on the facial, that would actually sit just facial to this and create that stable situation while that healing area really allowed 6 months of tissue development. What that allowed us to do then is to create an ideal tissue situation where the papilla is right where we want it, the emergence profile is right where we want it, and then we cement with Ceramir, and we get this just beautiful response of the tissue. We can take our radiograph and see that there's no cement present, and it works out beautifully. And this happens time and time again. I'll show you another patient that was a can of worms of mine who came in with deep, deep caries, what I thought was caries, on tooth number 8, next to number 7. And she said, I'd really like these crowns replaced. They're not so attractive. And I said, great, we can take off those old PFMs and I can do some beautiful crowns on them. And I really didn't look too astutely, other than I saw kind of an open margin on both, and said, okay, I got this. Well, when I got the crown off number 8, and I should have looked more carefully at this PA, I didn't really see what was going on right here so well. I just thought it was, gosh, a large pulp chamber. And what happened was it turned out to be a huge resorptive lesion right here. Now, here's the problem. Patient's presenting for a crown and a crown. And now I've got this huge resorption, and really likely a lateral periodontal cyst here, or endodontic cyst. And this is a non-restorable situation. So the patient came in to get 2 new crowns, and now I've got to tell the patient, oh my gosh, I am so sorry, this tooth is unrestorable, and we've either got to do a 3-unit bridge or an implant. Well, I didn't love the idea of a 3-unit bridge, mainly because the lateral right next door was endodontically treated. And when you read Peterson and Braggard's study of meta-analysis of survival rates of bridges, they actually do quite well compared to implants if both abutment teeth are not endodontically treated. Well, in this case, one was, and that really drops the survival rate of a bridge down considerably. And the 10-year survival rate drops under about 85%, where it would be at about 89% for either an implant or a 3-unit bridge on vital teeth. Well, with that said, we opted to do the implant, and we had some options. We could extract it, do an immediate implant, extract, do a bridge, extract, provisional on 7, and delayed loading. Come up with lots of different ways of doing this. Well, what we did is immediately temporize but not load the implant. We got great primary stability and was able to build an immediate temporary. But before we did that, in the interim, I did want to do a graft because resorption also often leads to that buccal bone loss. So what I did temporarily is cantilevered a little temporary off the lateral just while that graft developed. Once the graft was developed and we had solid bone, we took all this temporary, put in our implant, and started to train the tissue around that. And what we were able to do is then place a temporary abutment and cement a crown into place. Now, in this case, I wanted to use Ceramir cement just because of its biocompatibility, and I couldn't quite do a screw retain. So we got really nice tissue results, and then screwed in our zirconia abutment and cemented our final crowns in place, and got a great tissue response with the Ceramir cement. Now, these crowns have been in service for about 8 years. There's been absolutely no change to the tissue. And this is looking at the tissue contours. Following that, the tissue looks healthy and responsive, and it's held up beautifully in a 75-year-old patient. So I really think and encourage you to look at this cement as a really good option for you to use. Now, this patient became a great referral source for me, and she would always have patients or friends of hers comment on how great she looked and how nice a smile she had, and she'd always say, well, thanks to my dentist, because this front tooth isn't mine. It's an implant. And they're like, oh my gosh, that's crazy. So I'm going to move on to talking a little bit for the last few minutes of our program about modern pulp capping and whether it's direct or indirect. Now, pulp capping in the past is utilized either like a die-cal type material or occasionally a glass ionomer for indirect pulp capping. And the problem in pulp capping is whether or not the tooth has a great enough source of calcium to remineralize and to create tertiary dentin. And that's been the bane of pulp capping. So often when we pulp cap a tooth, we don't get that tertiary anatomy, we don't have a situation that is antibacterial, and the tooth eventually becomes necrotic, especially in the case of direct pulp caps. Indirect, maybe not so much. But for a long time, I was taught we put Di-Cal down, a glass ionomer over that, and then restore with conventional materials. And what would happen over time is I'd see those liners and bases wash out. In fact, I'd take out an old restoration, maybe it was an old amalgam, and those pulp caps had literally liquefied, and it'd be this big explosion of white. And like, well, that really is no longer a stable material. So for years, we have used successfully glass ionomers. Now, glass ionomers, I'll tell you this, in an individual with a high caries rate, as a restorative product, when you're doing direct dentistry and you have a patient with an uncontrolled caries rate, think glass ionomer first and think composite resin second. The reason being, in an uncontrolled environment, composite resins don't fare as well as a GI. So I'll use a Fuji 9 or a Keytac from 3M or Ionostar Plus or Molar from Voco as a glass ionomer. And I'll tell you, glass ionomers have become my patch and pray material. The problem is when we're in deep, deep caries and we put glass ionomers directly up against the pulp, we have a very high probability of pulpal necrosis due to the acid's presence in GIs. So when you're placing a GI, if it's an indirect situation, fine. As a pulp cap, it is fine. But when you're close to or you have a direct situation, you really should look at other ways of lining the tooth. So I want to talk a little bit about this. Now, this is a patient that came to me, and listen, I'll admit it. Sometimes practice is nothing more than trial and error. We try one thing, it works, we keep doing it. We try something else, it doesn't work, and we do something else. Now, this patient came in as a 90-year-old individual with beautifully unrestored teeth for the most part. They had a few crowns on posterior teeth, but their anterior teeth were their own. And I started to see, oh my gosh, look at these, look at these, look at these. And I began to go into each of these and treat them with composite. And I was meticulous. I had a band in place, I had an isolite in place, the field was well controlled, the caries was removed, and I'd placed some composites. 6 months to a year later, the patient would come back and I'd start to see some marginal breakdown around those composites. And I'd say, wow, this is not great. And you'd go out to the next recall and you'd start to see this recurrent caries right along the composite margin. So I said, okay, I got to get a new material for patch and pray dentistry. So I'd come in here, and the next one I did was, I'd start using glass ionomers. Now, the problem with this GI is it's right up against the pulp. And I was taught for years, it'll probably do okay as an indirect or near pulp capping material. But what happened to both these teeth is unfortunate. They both became necrotic over time and required 2 root canals. Now, I didn't have to crown them. And that's likely because, number one, this caries progressed right underneath here. And number 2, I had this glass ionomer too close to the pulp. And I really probably should have lined those teeth with something. But I never found that Di-Cal worked all that well. Well, things have changed and I do things differently now, but I like to show you some historic cases to give you some sense of how these things have changed. Today, if I had these lesions, I would simply use a GI as I did here, but first I would put a pulpal protectant, whether it be in an indirect setting or a direct setting. So I want to take you through that. Now, Ceramir has Protect LC. We've been talking about calcium-based resin-free products up until now, but this is basically a deviation from Ceramir using the calcium aluminate uh, product and adding a resin matrix that allows it to be light cured, but still creates that alkaline pH and allows for a large amount of calcium release and then the production of tertiary dentin. So it's important to recognize, to get tertiary dentin, a couple things have to happen. Number one, the pH has to be near neutral. So if you have an acidic environment, it's not going to happen. You're going to get dissolution, not apatite formation. Number two, you've got to have a source of calcium, an available source of calcium. Doesn't mean the calcium's in it, but is it available? And those two things will lead to that tertiary dentin. The third thing is you don't want the tooth to be having an inflammatory process, meaning you don't want the tooth to be inflamed, because that is counterproductive to the formation of tertiary dentin. So this product, Ceramere Protect LC, is really Ceramere cement mixed in with light curing capability that allows me to place this in a very simple fashion without any etching or treatment of the tooth structure, light cure it, holding it stable, then covering it with my restorative materials. Now I'm going to show you two clinical cases, and these are challenging clinical cases. I mean, they're hard, and they're really in an uncontrolled environment. So this is a study that Nate Lawson looked at. Nate Lawson's a researcher out of UAB Dental School, and he tested a number of products. He tested Dentsupply's product, he tested Bisco's Theracal LC, Limelight from Pulp Dent, BioCap from Denmat, and then the Ceramere Protect. And really what he's looking at is calcium release over time. Now, all of them initially, except for two, really showed some promising calcium release. But what you'll notice is the other four products tapered off very quickly. And the Protect LC kept going and releasing a lot of calcium, which leads us to the fact that it is the most likely of these to lead to that secondary dentin formation. Because of that high calcium release and that continued high calcium release. Now, one of the reasons that DiCal didn't work all that great is its calcium release really tapered off. So that's important to recognize. So this is just a cartoon showing that what the significant release of calcium in a direct pulp capping situation can do. That calcium will infiltrate and stimulate the production of hydroxyapatite that will then build tertiary dentin. And that's incredibly important. Now, I've been tracking these on patients. Number one, I don't want them to go pulpal, whether it be a direct or indirect exposure. Sometimes, the science says, hey, leave them indirect, do an indirect pulp cap. But sometimes, unfortunately, that caries is so enormous that you can't help but find the pulp, or the caries is already into the pulp. And you want to get that before it's necrotic. So here's a clinical situation on a very young patient, and it's so sad. She was a beautiful young lady with beautiful teeth who had gone through orthodontics, and she had had bands placed around all of her molars. Well, the problem was, although she's a beautiful young girl, she had terrible hygiene. And those brackets developed almost immediate demineralization and then subsequent very large caries. So what you see here is the first one she had, this huge band of decay around the buccal that was quite large. She had already had large buccal decay after ortho. We had to take off the band, restore this, put the band back on. The second time the band came back off, she had this huge lesion here. And I'm looking at these pulps in a 13-year-old and saying, there's no way that tooth is not necrotic. But keep in mind, in an individual at this age with these large pulp chambers, they have a very good chance, provided we provide them with a neutral pH, and um, and a product that will release calcium of creating that dentin. Now, this was an absolute disaster because this decay was now traveled well below the tissue level. And I'm like, this is a 13-year-old. I want her to have that second molar the rest of her life. So very troubling. Now, here it is when I had removed most of the decay. Now, I want you to see that I still have a little decay or staining up here. This was solid. And I've got the pulp here, and it's so large. In fact, the pulp is exposed all the way down to here, all the way down to here. The margin dives down below the tissue here and then comes back up. This is essentially the entire buccal surface. Now, I'd used some caries detect and removed 90% of the caries, and then decided at this point, we need to stop, or I'd have to initiate root canal treatment. You can see where she had these bands of demineralization from her brackets. This one had required restoration. We had already done a very large composite that wrapped around the distal, and now I've got from here all the way into the interproximal with a pulpal exposure. Now, I've got an isolite on here. There's no way of me isolating this with a rubber dam. It's impossible because I can't get a clamp on here below the tissue. I'd have to do flap surgery. So what do? I place a cord in place, and I'll put my Protect in place. Now, I used a fair bit of the Protect LC because there was a large band of caries exposure. But keep in mind, this is 4 millimeters into the tooth. I've got plenty of room to cover this with my restorative material. At that point, now that I've got a cord in place and I can see my cavo surface right here, and I can see my restoration, I'll go ahead and restore this. Well, the problem with this tooth is there's a slight probability of going endo. We're going to leave this as is to give that tertiary dentin the greatest chance for formation. I'm not going back into this tooth and crowning it, and hopefully we're not going to endo it until this patient is at an age where she's got her hygiene under control and is warding off the disease. So I placed a cord and then restored this. Now, this was restored with composite resin over the Ceramir Protect LC, and that LC is going to provide calcium. I saw her at a week's recall, called her 3 weeks later, and the tooth is completely asymptomatic. Why? Because what's right up against the pulp is pH neutral and releasing calcium, giving this tooth the greatest chance of survival. Now, as I near the end of the program, I want to go over a case of indirect pulp capping using the Protect LC. And this is really the favored technique where you get close to the pulp, but you don't expose the pulp, but you never know where the lesions take you. Now, this was in a patient who had a tough time closing all the way for our bite wings, and had developed interproximal caries from not flossing. Now, this is a bit misleading because right here you see this big round thing. When you see these on a radiograph and then you see this caries here, always check for a large cuspa carabelli because that can throw off your diagnosis. So look in the mouth, and sure enough, she's got this huge cuspa carabelli. So the decay is really interproximal. And here's our decay. Here it is. It's broken through the DEJ, but I can see that this decay is quite large. In fact, I believed it dipped all the way down to here. The problem is this cuspa carabelli is really obscuring my full view of this. So based on a lesion we treated prior to this back here, I said this one is going to be quite large. So inform the patient that this could be encroaching on the pulp, but we don't know. So what do I use? Well, I prep down into here. I use an isolite at all times. Here's the class 2 we did, huge class 2, extended all the way out to here and all the way out to there. A very large class 2. This one didn't get quite as large buccolingually, but it's up under these cusps, and I'm just ever so close. Now, I use caries detecting dye from Ultradent, and I use this product from Ultradent called an Inner Guard. This provides me some separation, and this prevents me from damaging the adjacent tooth. So I drop that in, do my prep, and immediately once I get my prep done, I'll go ahead and I drop in my matrix system. Then I put in the Protect LC. Now, this is covering that entire portion in a very thin sparing amount, but I covered all of the dentin based on where I thought those pulp horns may be, and did that. Now I've got a lot of area to cover, and I was actually able to cover this with then a flowable composite. Here I'm using the Triodent system. My matrix band is properly placed, and I've got good seal here, and a nice marginal ridge curve. And I went ahead and placed over that a flowable composite. Now at this point, I'm ready to build this all the way up to the occlusal. In this case, I used genial injectable flow as my composite over the Ceramir Protect LC, and capped that with the genial composite in an A1 shade. So we got our restoration finished, contoured. We got some anatomy in here. Here's our central pit, and then our mesial pit, marginal ridge, and really nice anatomical curvature, and a restoration that's really hard to detect. Now, the nice thing about this is at follow-up, the tooth remains asymptomatic. And it's really interesting to see these very deep restorations where in years past, I'm like, oh, this tooth is a goner. This is going endo. Survive and be just fine. And what we hope to see over time is that continued development through calcium release from Protect LC to build that border between pulp and tooth structure. Doesn't mean we ran into these. We leave them, let them be until they truly need some other care. Well, with that said, I want to thank all of you for listening tonight. I hope some of the information I provided you was helpful in your practices. I'm going to put up my last slide, which is a thank you, and my email address again. With that said, I'm going to bring up some of the questions that are present here and see if I can answer. If I can't answer the question, or I see a repeat question, I'll let you know. So the question from Ocean 11509 is, does Ceramir expand? Well, the expansion is really self-limited to the space that may be present. So at the margin, it doesn't necessarily expand, meaning it's going to move your crown and pop your crown off. But it does fill any void that may be present through that apatite deposition that occurs. So it's really not expansion. There's no true volumetric expansion. Rather, it will fill those voids selectively based on space available and the release of the calcium. So anonymous attendee asked, what's the retention like? Does it bond to Emax and zirconia? So the retention is good, quite good, provided that you follow the principles of crown preparation. If you've got an over-tapered situation, grossly over-tapered, you're going to be challenged with Ceramir, but you're also going to be challenged with an RMGI or a GI cement. So it is more a micromechanical bond as well as a chemical bond that is enough to hold in crowns. So I haven't really had crowns come off with Ceramir, and I guess that's the biggest question. So anonymous attendee also asks, I listened to a speaker this week and they said that all light-cured materials like Theracal, etc., are cytotoxic to the pulp. Well, I don't ever listen to an individual who says all or nothing. And I would always ask that individual if they have the evidence for that. I think those all statements aren't really appropriate, especially with new science emerging. So I disagree with that. I got a thank you from Dr. Bernard. Thank you. The biodentine people say you shouldn't use any LC products in direct contact with the pulp. How does that reconcile with your LC direct pulp cap? Well, that's not what the evidence says. Biodentine is going to say that because biodentine does not make an like cured product. So, you have to consider your source. With that said, I'm tracking these very closely because this is a relatively new product. At this point, I've had 0 teeth go pulpal. So thank you for that. The next question comes from, is the separator band good for crown prepping? Oh, honestly, I don't think it is necessarily great for crown prepping. It is nice for veneer prepping where you're not going to break a contact, but it's not great in situations where you're going to break contacts, because it really, once you break the contact, it's likely going to fly on you. So don't use it for breaking contacts, but for veneer preps, it's great when you're trying to stay facial to that. Another question was, can you use SDF under Ceramere? And the answer would be, I don't really see any reason why you couldn't or shouldn't. So there's a couple of questions on biodentine and how it compares to Ceramere Protect. I haven't looked at any comparison studies myself, so unfortunately, Barbara, I can't answer your question. And I want to thank you all again for listening to this. Thanks, guys. Take care.